And the first regulations that imposed restrictions on the population became law on the 26th of March 2020 as part of the first lockdown.
No, the first regulations that allowed for restrictions were put in place in to ensure that we could have a legal quarantine for those individuals who we needed to under the 1984 Act in February.
Yes, I appreciate that. It doesn't matter. We'll move on. I was talking really about the first lockdown. But in any event, on the 13th of May, the regulations were amended, weren't they, to allow a person from one household to meet a person from another household for the purposes of outdoor exercise. 13th of May.
I can't remember the exact date, but that feels about right.
And the regulations were similarly relaxed in relation to outdoor exercise during the second lockdown in November and in relation to the third lockdown in January 2021. Does that sound about right?
In the third lockdown, we were clear that we were going to allow people to have more outdoor exercise because outdoor was known by then with confidence to be safer than indoors.
Yeah. And indeed, in your pandemic diaries, and I can't put this on the screen because this is not on the system, in January 2021, you observed the importance of outdoor exercise for you personally in relation to physical and mental health. You used to run part of the way to work with your brother every day.
That's correct, yes.
Now, why didn't you, or why didn't the government, take steps to relax those regulations so that, for example, in relation to outdoor exercise and recreation, so that all young children, say under the age of 12, could play with others their own age?
Well, we did consider measures like that because the impact of the virus on children was obviously much lower than on adults, and in particular on older adults. There were two concerns that were raised by the clinicians. One is that when you have children playing together, you still can have transmission from one to another, and therefore from one household to another. And the second is that when children play together, normally adults are present too, especially younger children. And therefore it might encourage transmission that way. So this is something that I remember conversations about. I don't know the date, but we were concerned that it would have an upward impact on transmission and therefore on the amount of disease and death.
Which clinicians?
I specifically remember a conversation with the Chief Medical Officer about this, and there is in the WhatsApps, there is reference by the Chief Medical Officer. Off the top of my head, at one point he says, I'd be more worried about the parents on the touchline.
You're aware, aren't you, that Scotland exempted children under 12 from their regulations in July 2020, and Wales exempted children under the age of 11 from their regulations in September 2020, aren't you?
I'm aware of the differences between the regulations, yes.
And you're not suggesting, are you, that Scotland and Wales put the lives of their people at risk by effectively exempting children from their social distancing regulations as they did?
I'm making the point that the discussions that we had were based on clinical advice. I know that the clinical advice was closely coordinated between the nations, and what mattered was the overall impact of the measures in place on R and making sure we kept R below 1 and therefore kept the virus under control. So it was a matter of the overall package.
Well, I should make it clear, in the interest of fairness, and we may hear more about this in a later module on education and children, but Sir Chris Whitty did not tell this inquiry that he advised you to take a different approach for England than the approach that was taken in Scotland and Wales. I think you're entitled to know that, okay? But I'm going to move on.
I didn't say that he did. I think it's I've simply given the evidence of what happened in my experience.
Did you know at the time, in the summer and autumn of 2020, that the former Children's Commissioner for England, Anne Longfield, and numerous charities and non-governmental organizations working with children, including those who I represent, were asking the government specifically to exempt children from the regulations from May 2020 onwards.
I was aware of their public communications, and if they wrote to me privately, I would have been aware of that too. I was also aware of the overriding need to keep R below 1 in order to make sure that the virus affected as few people as possible, especially older people who could catch it from their younger relatives or contact with younger people.
You're not suggesting, are you, Mr. Hancock, that relaxing the rules in relation to children would have taken the R number above 1, are you?
Yes,
You're
of
not
course.
honestly suggesting that, are you?
Yes, of course I am. That is the clear medical position, and understandably, because one of the things we discovered was that children could pass the disease on to children, and whilst both asymptomatic, they could then pass it on to elder relatives. So yes, that was one of the many things we had to contend with, yes.
And you're saying you had received medical advice to that effect?
Yes.
Or was it expert advice you're saying, Mr. Hancock? I think we need to pick up more
I'm sorry,
medical advice.
Without any notice of this line of questioning, I can't give you the precise details of the documents, but it was clearly understood, my clear understanding, and essentially a consensus position that we reached. This is all obviously extremely unfortunate. It's one of the consequences of the fact this disease passes from one person to another when you don't have symptoms.
And Mr. Hancock, even in January 2021, when we went into the third lockdown, when children under 5 were exempted from the regulations, in England, children aged 5 to 12 who were too young to leave home independently were not similarly exempted, as they were in Scotland and Wales. You know that, don't you?
I'm aware of the different regulations. I'm also aware of the reasons that we brought in those regulations. Nobody wanted these regulations. Nobody wanted to have to put these burdens on people. But I did want to stop the virus and to stop so many people dying from it. We've seen the testimony of the consequences of this disease. It was a horrific virus, and it was my responsibility to ensure that as few people got it as possible, and that was extremely difficult. It involved doing things nobody would want to do in any normal circumstances. And from the tone of the questions, I get the impression that you think that was a you're inviting me to say that that was a mistake. It wasn't a mistake to put in place the restrictions that saved lives. In fact, my overall point is that we needed to have done that sooner in order for there to have been fewer deaths. That's what I was working for.
And it wasn't simply the children's sector that was asking the government to relax the rules in respect of children. It was even people within government, wasn't it? And I'll give you an example. Could we have on the screen, please, 176785 at page 24. These are WhatsApp messages between you and Helen Whately, then Minister of State in the Department of Health and Social Care. Is that right?
Yes, that's what these WhatsApps are.
And if we have a look at the entry, please, for the 11th of October at 15:46:59. Do you have that on your screen?
Yeah.
Helen Whately says to you, wish we could loosen on children under 12 on rule of 6 for tier 1.
Yeah.
And then she goes on an hour or so later to say it makes such a difference for families, and there isn't a robust rationale for it. So she clearly doesn't agree with you about there being a robust rationale for it. Now is a really good chance to show we have listened. Lots of MPs were pushing on this during last week's debates. Do you see that?
Of course I can see it. I can read. Thank you.
Well, I'm glad to hear it. And then you say they don't want to go there on this. And she says, are we they? And then you say, as in number 10, also on curfew, they don't want to shift an inch. So, I mean, correct me if I'm wrong, but she's saying there's no rationale for children not being exempted from the rule of 6. And you're saying number 10 do not wish to shift an inch on this. Is that right?
What I'd say in response to this exchange is, firstly, a big picture point. You can see the high level of professionalism and the way with which those who reported to me, including Helen Whately, could bring issues to my attention and express that they disagreed with me in a wholly professional way. And with respect to yesterday's evidence, I just think, Chair, I make that point because this is how we ran the health department, and I encouraged people to raise questions with me. I also wished we could have loosened on children, but we couldn't because we needed to keep R below 1. At this point, on the 11th of October, you'll know that the incidence of COVID was rising. That meant that in the future, more people were going to die each day than were dying on this date. And my argument, as we've discussed in earlier evidence, was that we needed to do more at this point to stop the virus, to save lives. That's the argument I was making. And of course I understand the impact on children. I have 3 children of my own. Of course I shared a wish that we didn't have to do any of this, but we did. And the reason we did was because otherwise more people would die. I think there was a robust rationale for it, and I therefore listened, as you can see, debated briefly with Helen, and also I don't know whether I checked with Number 10 in that 15 minutes in between 5:40 and 5:54, or whether I already knew that they didn't want to change their position. We were under significant political pressure to lift certain restrictions. I thought that would have been a mistake and more people would have died. There was an active campaign against the restrictions at this point. And as I say, the clear advice to me was that because of asymptomatic transmission of this virus, unfortunately, it did pass from child to child and therefore from household to household. And that's why we kept the measures as they are.
Thank you, Mr. Menon. I'm afraid that's it.
Can I just make one final point? It's on the same theme. It'll take less than a minute, my lady. Mr. Hancock, to be fair to you, you need to know that this inquiry has heard evidence in relation to what Sir Patrick Vallance put in his notebooks, that at this very time in October, there is evidence before this inquiry that SAGE was pushing for exempting children from the rule of 6. And I'm afraid that does contradict the evidence that you've just given, doesn't it?
I haven't seen that evidence. All I can give you is the testimony of what I was told at the time and the overriding strategic objective I had to save lives.
Thank you, Mr. Menon. Mr. Freeman.
Thank you, my lady.
Thank you, my lady. Good morning, Mr. Hancock. I act for 4 national disabled people's organisations. And can I start with adult social care as of early March 2020? And we're particularly concerned with the implications of the MPIs for disabled people, whose care systems would likely be overhauled or, at best, very significantly be challenged. And for context, 2 points, if I may. First, the annual published NHS digital records from October 2019 indicate, and I hope you're taking it from me, that there were 841,850 people who received long-term adult social care support in 2018 to 19. And that a very significant number of those people were disabled people.
For example, of all ages or of working age?
I'm going to give you an example.
Okay.
For example, for those aged between 18 and 64,
yeah.
The most common reason for support was learning disabilities,
yeah.
and that's 45.5%, followed by physical support, 29.2%, and mental health support, 20%. Second point for context, and bearing in mind your characterisation of the function of central government, including to do what only the centre can do, we know that there was no dedicated cross-departmental government plan as of March 2020 to lead on the shielding and non-shielding challenges that hit disabled people specifically. that's been confirmed by the Minister for Disabled People to the chair in this module, and by Marcus Bell, the director of the Equality Hub in module 1.
All I'd say is it's valuable to be more precise within March, because I commissioned what became the shielding plan in early March, and so by late March it was extremely well advanced.
Yes, well, I'm not going to go too far into that. Safe to say this, because I'll ask you a question, you may add to it, but the shielding plan and the battle plan in relation to all of your work, of course, at that stage in March and how it evolved in its first incarnation, Battle Plan version 1 was for the clinically vulnerable who needed to shield, and then we know later in May that non-shielding vulnerability came into play. Simon Case took it up. We won't have a debate about that was outside of your immediate responsibility. But let me just ask you this. As Secretary of State for both health and social care, including adult social care, did you raise the issue of a lack of any cross-departmental plan, and I emphasise that, for disabled people in central government at the time?
We discussed the importance of work to protect those who were particularly vulnerable to the disease.
Yes.
And that's and so I answer that way because we were precise about it in how we thought about it, which is what matters is the vulnerability to this disease, and therefore one disability may lead you much more vulnerable to the disease. Another disability may lead you no more vulnerable to the disease than somebody else of your age and other characteristics.
Yes, so I understand that's inside your department, focusing on clinical issue. And my question is a more general one of the various vulnerabilities that were going to arise, both the clinical vulnerability that you've just focused on, and, as it were, the non-shielding vulnerability, paradigmatically determined by the nature and the harsh nature of the lockdown measures and the like. Did you raise, as it were, the absence or the sufficiency of cross-departmental government planning for the whole of that impact?
My recollection is that this was discussed at one of the MIGs, the Ministerial Implementation Groups, but I don't have a date for you of that.
And beyond the obvious clinical-focused responsibilities of your department, whose responsibility in government, either personally or, let us say, departmentally or institutionally, would it have been to raise the need for cross-departmental planning across the range of clinical and non-clinical vulnerabilities arising out of the COVID response?
Well, the answer is that in the pandemic, that is a very big question, because the issue of those who are more clinically vulnerable was clearly a cross-departmental one at the heart of the overall response to COVID. And so the Chief Medical Officer and others would have been heavily engaged on that side. The consequences of the measures needed to tackle COVID that particularly made life harsher and more difficult for those with disabilities, including those who were no more at risk from COVID than the general population, those issues were considered. I think that the lead, of course, there's a Minister for Disabilities, and I know that he's given evidence, but that would have been more likely to have fallen within MHCLG's remit, and they led on the overall shielding and then the allied non-shielding, non-clinically vulnerable support. But there was also a heavy Cabinet Office support for that. And as you say, Simon Case was initially brought into government in order to lead on that particular piece of work, which was very important.
Thank you. Could we go to INQ 409324, page 6? And I'm turning to care homes, specifically, Mr. Hancock.
Okay.
These are WhatsApp messages amongst you and your staff, but I want to focus on the one with Jamie Njoku Goodwin. It's dated 4th of April, Njoku Goodwin, dated 4th of April 2020. And we've seen this morning that he was actually on the 6th of March care homes meeting that Miss Morris King's Council took you to.
Yes.
So first, you told the chair yesterday that this was your media advisor.
Yes.
And he became a director of strategy later on in number 10 Downing Street. His statement to the inquiry indicates that he worked for you on media management and also wider and political strategic issues. Is that addition?
Yes, that's a good summary.
Yes. Now, yesterday, Council of the Inquiry asked you to look at an exchange on the 13th of May 2020 about what to say to the public about having locked down the care homes.
Yeah.
And he had warned you, Matt, we might have some issues with you telling the PM we locked down care homes before the rest of the country. Can I just read this exchange of 5 weeks earlier and the third JN entry on that page? On testing, do we need to have a specific push on testing in care homes?
Yeah.
We're testing hospital admissions and clinical patients at risks. Do we need a push on testing people in care?
Yeah.
Or at least we have some sort of focused effort on testing people in care. I know it's complex, and the people are dying in care homes are often people who are near the end regardless. But I worry if a load of people in care start dying, there will be front pages demanding why we weren't testing people in care homes. Do we need to get ahead of this now? Mm-hmm. And you say, let's have rapid advice on this, tying together all the angles. Of that message of the 4th of April 2020, when replying, you do not correct the misconception of your advisor that those in care homes include not just those who were near the end regardless, but also disabled people who are not near the end, but living in long-term residential care or settings from a young age. Now, did you have that reality in the forefront of your mind at the time? And bluntly, why not correct your advisor of that serious misconception?
Firstly, I absolutely had that at the front of my mind, and before the pandemic had done significant work in trying to improve outcomes for those who were in adult social care of working age with disabilities, including trying to get more support in the community for discharge where that was appropriate. So I'd done work on this, and I, of course, knew that. The response that I gave at a time when I was exceptionally busy, does the fact that it doesn't state all of that in no way implies that that wasn't what I was thinking. Mm-hmm. And asking for advice is a device I would use typically when I was brought a complex issue. I cared about it, wanted to make progress on it, but I thought that it was best not done over WhatsApp. And as you can see, 2 messages down, Layla was my private secretary, and she's on the group, and she says, I'll commission now. So this is the system. That is a typical exchange. A complex issue is brought by a political advisor. Jamie Njoku Goodwin was one of the most exceptional public servants, and his advice to me was excellent. And I respected it. However, he's coming at this from a comms angle in terms of what the newspapers might say. I was absolutely determined on this, as on so many other issues, to be guided by the science, which is why I would have wanted formal advice. After all, I can tell you now that the reason that we did not at that point have as much testing in care homes as many would have wanted was that we didn't have enough tests, and the clinical prioritization of who got tests in what order was absolutely something that I wouldn't have interfered with. I would have taken that as read.
Understood. Can we then move on to the emerging data from testing in relation to disabled people? And can I really then, because of the chair's intervention, crunch it down? During the course of the summer, very significant statistics emerged that amount to 59% of those who have died from COVID between the 2nd of March and July were disabled people. Now, do you recall becoming aware of those very significant figures?
Yes.
And if so, roughly, we won't hold you to exact date, but roughly when do you think you did become aware of those kind of figures?
Off the top of my head, I don't know. We can discover it in the paperwork if necessary.
But given this point, what I'll call the Badenoch Review, very generally, commissioned in June, as you put it in your statement, quote, to improve understanding of drivers for disparities to inform decision making. Why, as far as you were concerned, did the Badenoch Review not look at disabled people as well as the very important matter of ethnic minorities?
My initial understanding of the Commission to Public Health England, which ultimately became the Badenoch Review, because it all came from this work within Public Health England, was that it was to look at disparities, and I would take that to involve all protected characteristics.
Quite.
And that was my approach to it. Of course, there was a complication here because of comorbidity.
Yes.
Not least because of the strongest correlation with risk from COVID was, of course, age.
Mr. Hancock, in view of time, because we've heard quite a lot of evidence, my only question is, what was your understanding about why it focused as it did on ethnic minorities and not disabled people? Did you have any understanding about why it focused?
No, my understanding before it was passed to Kemi Badenoch was that it was a question of disparities as a whole.
Yes, and just last thing, Madam, if I made one.
Mr. Freedman, thank you.
I'm sorry.
Sorry, we've got so much to get through. I know these are important issues, the people you represent, in every case, including Mr. Menon, but we have to get on. I've got so many to get through. Mr. Thomas.
Very well, my lady.
Sorry about the layout.
Yes, and I'll answer to the chair, I'm told, so I apologise that
I'll get used to seeing your back.
Right.
I represent the Federation of Ethnic Minority Healthcare Organisations,
yes,
FEMHO, the very frontline workers that the public was clapping every Thursday evening at about 8 p.m. I'm sure you remember.
Absolutely.
Now, I've only got a small handful of questions that I wish to explore with you, and these can be divided into two topics. So let me turn to the first topic. This morning you said, Mr. Hancock, that, quote, I was particularly struck by the death of the first 4 NHS doctors, 3 of whom were from an ethnic minority background. I was acutely aware of the disproportionate impact on those from ethnic minority backgrounds, especially among the wider NHS workforce.
Yes.
Etc., etc. Question. Please help me with this. What steps, if any, did you take to engage with the Black, Asian, ethnic minority leaders in healthcare about the disproportionate deaths within their ranks during this early period?
Well, I engaged with the NHS leadership on this question, including people from all ethnicities, and I was engaged heavily in issues around firstly, the evident higher risk of those from ethnic minority backgrounds to the disease, but also the more long-standing issue of racism within the NHS, which came to light in a report that had been begun before the pandemic. So this is an issue I was heavily involved in. The NHS can't work without its amazing, diverse workforce, and it was something that I was concerned about well before the pandemic.
Yeah. Secretary of State or former Secretary of State, let me just put this to you clearly and bluntly. Did you or did you not at this time specifically engage with the leadership of any ethnic minority healthcare body? That's the question.
I engaged with ethnic minority leaders across the NHS and indeed social care, specifically in terms of meetings. We'll have to look through the diary to understand, to see how, who, and I'm very happy to do that.
Well, okay, let me move on to the second question. What concrete steps did you take as Health Secretary to mitigate against the unequal impact of the pandemic on Black, Asians and minority ethnic healthcare workers and patients?
Well, there were a number of things that we had to do. As Professor Van Tam set out in his evidence, making sure, for instance, that there was PPE that would fit people from any ethnic minority background or from different ethnic minority backgrounds was an important issue that came to light and that we worked on. And there was a wider question of how to protect all healthcare staff, because there was a disproportionate impact of the virus on people from ethnic minority backgrounds because they were disproportionately engaged in patient-facing roles in the NHS. And by disproportionate, I mean that in terms of the numbers, the statistics. It's not, not about whether that should have been the case or not, which is an important question. But at this point, it was about how do we protect people in those, especially in those patient-facing roles.
Would you agree that part of this was as a result of structural inequalities? Would you agree with that?
Yes, absolutely. And in fact, part of the work was about trying to understand what is to do with structural inequalities and the higher likelihood of people in especially patient-facing and service roles being from ethnic minority backgrounds, and how much was a clinical question of the higher likelihood of COVID causing severe disease and death according to ethnic background. And those were two overlapping and incredibly important considerations that the initially PHE and then Badenoch review was intended to try to get to the bottom of.
Right, let me move on. I've used up half of my time. Can we call up INQ 000176785, please? This is the WhatsApp exchange between you and Helen Whatley in June 2020. Ms. Whatley writes to you, quote, "One more thing on the NHS workforce. I think that black, Asian and minority ethnic next steps proposed are important but don't go far enough. There's systemic racism in some parts of the NHS, as seen in the NHS BT. Now could be a good moment to kick off a proper piece of work to investigate and tackle it." You respond by saying, yes. Agree 100%. Can you make that happen? And she confirmed that she'd be delighted to do so. A couple of days later, she messages you again and raises that, quote, no one seems to be mentioning the NHSE risk reduction framework, which recognises age and ethnicity as a risk factor.
Yeah.
And she says that she's flagged that with number 10.
Yeah.
Right. So can we agree this? You accept, do you not, Ms. Whatley's assertions that there was systemic racism in the NHS? That's correct. We can agree that, yes?
Yes, and I'd in fact addressed exactly this question even before the pandemic, given a speech on it, referred to it in 2019, and there was this internal report into racist behaviour in NHS BT that was published on the 9th of June, so the day before this exchange started.
So we've got that response in mind and what you said earlier today, but let me ask you this. And I've seen that you flagged it number 10 and Miss Badenoch.
Yeah.
But let me ask you this. Did you or Ms. Whatley take any further steps regarding the recognition of ethnicity as a risk factor, aside from flagging it to number 10? And if not, why not?
Yes, well, so she flagged it to Ed Argar, who's another minister in the department responsible for the NHS, whereas Helen Whatley was the minister responsible for social care, and number 10. She was also had responsibility for the NHS workforce, hence her interest in this area. Yes, what happened was that this is just before the Badenoch review is announced. So what happened was that in order to strengthen the response in this area, the Department for Equalities was essentially brought in to do this.
Okay. Was it raised within senior personnel within the NHS, for example, as a guidance or as a reminder?
Yes, especially in the context of the NHS-BT report, which was an important report and needed action to respond to. I mean, this was something I really care about, and took the action that was necessary. And you can see by my immediate reaction within 10 minutes, yes, agree 100%.
Right, let me move on to my last questions. I've got two more last questions. I want to get them done very quickly. It's alleged that a chapter was removed from the Public Health England report on disparate impact on Black, Asian and minority ethnic groups prior to publication. And media reports at the time suggest that this was at your office's request. One such article states, quote, one source with the knowledge of the review said the section did not survive contact Matt Hancock's office over the weekend. And if you need the reference is INQ 000308410. I'm not asking that it be called up, that's just the reference.
Yeah.
Exclusive government censored Black, Asian, minority ethnic COVID risk reviews news health service journal.
Yeah.
Question, can you explain the circumstances surrounding this paragraph's removal?
I don't know whether a paragraph was removed or not. I can't recall that. But I do recall there being a public discussion along the lines that is suggested by the HSJ report. I saw Minister Badenoch's testimony to this inquiry, and I agree entirely with what she said. I accept that the decision to change the report into two reports, one essentially reporting the evidence that had been put forward, and another essentially a statistical and scientific report. I accept that caused a distrust in the process. Honestly, my response to the paperwork that you've suggested, which you mentioned, which I've read, is that if that happened, and I'm not aware of whether I had any engagement with it at that time, it says Matt Hancock's office, it may have been that this was the beginning of the separation of this report into two separate reports, and I concur with what Kemi Badenoch said.
Right, Ms. Hancock, let me ask you my last question. Can we agree on this, Mr. Hancock? That on reflection, the UK's government was not as well prepared and equipped to deal with the challenges of the pandemic that were experienced by Black, Asian and minority ethnic healthcare workers. That is, the disproportionate death rates and worse adverse health outcomes. Can we agree on that?
Well, I think that's true. It's also true of the response in terms of everybody. And I think that the lessons that we're learning here, specifically in terms of disparities and the impact, disproportionate impact on people from ethnic minority backgrounds, is a very important part of the lessons that we need to learn for the future.
I think we're agreed. I think
we've agreed on almost everything.
I think we have. Thank you.
Thank you, Mr. Thomas. Mr. Stanton.
Thank you, Madam Lady.
Oh, again behind you, I'm afraid, Mr. Hancock.
Good afternoon, Mr. Hancock. I'm sorry about this slightly awkward positioning. I represent the British Medical Association, and I'll be asking you some questions concerning the circumstances of doctors and healthcare workers. I'd like to highlight a couple of points of relevant background before I ask you the questions. The first is a piece of information I think you'll be aware of, and I don't think we'll need to bring it up on screen. It's an ONS survey from July 2020, which showed that healthcare workers and social care workers were at 6 times more increased risk of infection.
Yes, of course.
And just for the transcript, that reference is INQ 000271363. The second piece of information, which I think will be helpful, and I'd like to bring up on screen, is an email from Professor Van Tam,
right at the start of the pandemic on the 14th of January. This is at INQ 000 151 314, and hopefully you've got that before you. And it's just the first point in the email that I'd like to bring to your attention. Professor Van Tam is providing some advice to your department right at the early stages about triggers for escalating the response.
Yeah.
And trigger one, as you can see, is in relation to infections amongst healthcare workers. And he makes the point in a style which we've become familiar with, that healthcare workers are always the canary in the coal mine.
Yeah.
By which he obviously means they're the first identifiable group that will become infected, and as such, they'll operate as an early warning system.
Specifically of person-to-person transmission.
Yes, thank you. So with these points about increased risk in mind, and thinking about your representations throughout the summer of 2020 and into the autumn,
yeah,
about the need for caution when opening up,
yeah,
I'd like to ask you about the extent to which you felt you were able to advocate on behalf of healthcare workers who had faced a traumatic experience in dealing with the first wave,
yeah,
suffered high levels of infection, and desperately needed an opportunity to recover,
yes,
and, if possible, to avoid a second wave.
Yes, I felt that argument very deeply.
Could you help the inquiry with any insights about any obstacles you might have faced in this regard?
Well, the obstacles are were described and discussed in the questioning from Mr. Keith, because in the same way that to tackle long COVID, you need to tackle COVID, to stop healthcare workers dying from COVID, you need to tackle COVID. Now, there are also specific actions that you can take. You asked specifically about the summer, and of course, by the summer, we did have a very significant testing operation, and testing in hospitals. But earlier we were discussing the challenges of getting testing into care homes, and in a way, your question demonstrates that there are other priorities too that need to be considered. And so in that instance, I always took clinical advice on that prioritization. But yes, there was, and the same goes for PPE, by the way, where there was this tension. Where do you use your PPE? And the argument that you are rightly, correctly, and understandably making is healthcare workers are amongst those who are most highly affected. It was, for instance, why we put healthcare workers in the very first group to get the vaccine.
Yes, thank you. Can I move on to a sort of connected issue and one that also concerns risk of infection? Can I ask you about your understanding of airborne transmission?
Yes.
What were you advised about this risk, and when did you become aware that it was a significant route of transmission? So, just to be totally clear, are you asking about the distinction between droplet transmission and airborne transmission through essentially aerosol? Yes, I am. Okay, so this was a really, really important point, and sometimes quite complicated to describe, and also the science behind it was very complicated to ascertain. So how the virus spread from one person to another is obviously an absolutely critical part of transmission, not only the rate of transmission, but how. And early on, based on previous coronaviruses, it was largely assumed that it was droplets that made transmission happen, and therefore not being close to somebody was one of the most important things. But it became clear through the early summer of 2020 that, in fact, aerosol, airborne transmission was more important. So it was a bit like if you have a I remember the very first description, which again was given to me by Professor Van Tam in his eloquent way. If you have a smoky candle, the way that the smoke will go in the whole room, the consequence of that is ventilation. What became seen as much more important and is more important for dealing with
the transmission of COVID than droplets. But that was not understood at the start because it was a novel disease, and the starting point was an assumption that the transmission was the same as SARS-CoV-1.
Thank you. You spoke at length yesterday about your regrets in relation to asymptomatic transmission. Do you think there are any parallels and lessons to be learned with aerosol transmission? For example, should a more precautionary approach have been taken?
With hindsight, obviously, but I think at the time, the science on this was really was unclear. But I do think, to your point, a lesson for the future is that when you have a disease that spreads without necessarily person-to-person touch, then you should immediately assume that good ventilation should be part of your infection control procedures.
Thank you. I'll move now to my last question area. You'd mentioned earlier that during the early summer of 2020, airborne transmission became more important, or
yes,
it was realised that it was more significant. Can I ask you about decisions taken in June, at the end of June, to stop purchasing PPE? So you've told us about your direction to begin purchasing, I think, towards the end of January.
Right at the end of January, yeah.
Obviously, that does need to come to an end at some point, and at the end of June, stop notices were put on purchasing of PPE. Your Permanent Secretary, Sir Christopher Wormald, addresses this in his statement. FFP3 masks were no longer purchased after the 30th of June. And as you'll be aware, these are the masks that provide maximum protection from airborne virus. Given that the awareness of the risks of airborne virus were growing at this time, and given the likelihood that a second wave was coming, and also given the shortages of this very important piece of equipment, do you think the risks of transmission, aerosol transmission, were fully factored into this decision to stop purchasing?
I don't know. We'd have to look at the chronology. I don't know the date of my conversation that I just described with Professor Van Tam. And the first hard evidence I saw on this was evidence from a Spanish study. So this was clearly an international issue. Having said all of that, it is absolutely clear that this is an important part of the lessons learned exercise, because having the right stockpile in a pickable format so that you can get it out quickly in a crisis of kit that fits everybody, no matter their gender or ethnic background, is a very important lesson for the future. So irrespective of the chronology, which I'm happy to look at in the paperwork, for the future, it's not just about having a PPE stockpile, it's about having a PPE stockpile that is the most likely to be immediately and urgently useful in the event of a pandemic.
Thank you, Mr. Hancock.
Thank you, Mr. Stanton. Very grateful. Ms Davis. Ms Davis is over there, Mr. Hancock.
Mr. Hancock, you can see and hear me all right?
Yes.
Good. I ask questions on behalf of Southall Black Sisters and Solace Women's Aid, and you'll know that they're part of the Violence Against Women and Girls sector,
yes,
dealing with them. So my topics are on domestic abuse.
Yes.
Can I start with the regulations, which, as you say, you had responsibility for signing off?
Yes.
And under the regulations that came into force on the 26th of March, as you say, they weren't the first ones, but they were the ones for lockdown. Then the requirement was to stay at home. There were certain exemptions from that, and three of the exemptions is that people could leave if they had to access critical public services, including services provided to victims, such as victims of crime.
Yes.
And another one, they could leave in order to avoid injury or illness or escape a risk of harm.
Yes.
Did you have in mind the need to leave domestic abuse when
yes,
you approved those exemptions? Yes. Did you ever consider a parallel provision, and I'll put the scenario to you, in normal times, outside of lockdown, outside of pandemic, then it's not at all unusual for women, it's mainly women who have to leave as a result of domestic abuse. If they don't go to refuges, they might go to their sister or their mother or their best friend and stay in the spare room, get some respite time while they make decisions and so forth. There's nothing in the regulations that allows for somebody to let somebody else into her home in order to provide a refuge, a place of sanctuary, a safe place to think. Did you ever consider that sort of parallel provision, parallel to the idea that you could leave, you could also go and stay with a friend or a relative?
I don't recall that being brought to my attention, that consideration. I had an excellent team who cared very deeply about this subject and the impact of the regulations on people, as you say, mostly women who are subject to domestic abuse and violence. I also remember that Theresa May raised this in Parliament and was a strong advocate, but I don't recall that being brought to my attention. Had it been, I'm highly confident that I would have said that we should put in place such a provision, because the impact on the overall virus would have been relatively low, because although the numbers are far too big, they are, as a part of the population, relatively low. And in the same way that we realised that our initial regulations in terms of how they impacted funerals, for example, were much firmer in their interpretation on the ground than we had intended, and we therefore changed them. That is the sort of thing that I would have certainly been open to considering, and I'm pretty sure I would have been in favour of it had it been brought to my attention, but I haven't seen any paperwork on this question.
Open to considering is helpful, thank you. Let me move on to my next topic, and that's about testing key workers, and you talk about that in your statement, and setting up the priority scheme for testing key workers. Did you include as key workers in the domestic abuse sector, refuge workers and so forth?
I took it was not a Department for Health decision on what was a key worker, so I took the list of key workers as read. I can't, off the top of my head, remember, although there was who came up with the list, although I'm pretty sure it had cross-government sign-off because of the impact from every department. And policy with respect to domestic abuse is a Home Office matter, I think.
Principally.
Principally.
It's across government, but principally.
Exactly.
Yes.
So it would have been for the Home Office. I'm sorry to give you a sort of bureaucratic answer, but it would have been for the Home Office to put that forward. And if you like, I was, as the Health Secretary, I put forward key worker proposals from the areas I was responsible for, health and social care workers primarily, but also, for instance, those working on the vaccine. And then I was the recipient of the cross-government list.
If I tell you that Priti Patel's evidence is that she raised the issues of domestic abuse workers falling within key workers at Cobra on the 18th of March, does that jog your memory?
It doesn't, but I'm not at all surprised.
All right. And then my last question, my lady, is this, and it's about what you knew going into the autumn of 2020 when you're making decisions around tiers, and then the second, and then finally the third national lockdown. So by the summer of 2020, it was known to ministers that there had been an increase in domestic abuse as a result of lockdown,
yes.
Wasn't it?
Yes.
And you're also aware by June, in your witness statement, that there is the possibility of a second wave in winter, and you're working on preparations for that.
Yes.
Yes. So when you are then, as you told us this morning, advocating for the tier system in late September, early October, did you have in mind repercussions and the possibility of an additional increase in domestic abuse?
Yes. I had in mind that. I had in mind the impact on children. I had in mind the impact, the mental health impact on the population. I had in mind the impact on other health conditions. I had in mind the economic impact and the knock-on consequences of damage to the economy on people's health. We had all of these known costs, known damage from lockdown in mind. Of course, I had to weigh that against the, by then, known and clear damage and cost and loss of life from the virus and to me, as I've described earlier, the balance of those two horrible outcomes was clearly that we did need to take action to lock down, and so I think you can see from the paperwork that even ahead of the March lockdown, we knew that there would be consequences that were damaging of these lockdowns, but this virus was killing a lot of people and going to kill more, and you have to weigh these things together, and that's what I did.
And you would say the same weighing exercise happened for the second national lockdown in November and then the third one in January?
Absolutely, and we understood more of the negative consequences by then because we'd seen them. Nobody wanted these lockdowns, but the consequences, if we hadn't had them, would have been far, far worse.
And this is my very last question. And since you did take in mind or bear in mind all those weighty responsibilities, turning back again to domestic abuse, was there anything that you did specifically about that for the decisions that you made in the autumn and the winter?
I would have taken advice on that, and I would have taken that advice very seriously. I don't, without going back through the paperwork, I don't have a direct answer to the question. It isn't. I can't remember specifically, but I know that it was something that we considered.
Thank you, Mr. Hancock. Thank you, my lady.
Thank you, Ms Davis. Mr Jacobs. Mr Jacobs is also behind you. Mr Hancock, don't worry about it. He's used to people's backs as well.
Mr Hancock, I ask questions on behalf of the Trades Union Congress. First topic is financial support for self-isolation.
Yes.
An early step that was taken by the government on this issue in March 2020 was making sick pay available from day one rather than day three,
yes,
if you recall.
I do.
On the 3rd of March 2020, you can see it if you need to, but you sent a WhatsApp message saying that you were supportive of the fix, though it only solves half the problem.
Yes.
What was the other half of the problem that wasn't being solved, to your recollection?
Sick pay in the country is far, far too low. It's far lower than the European average. It encourages people to go to work when they should be getting better. Having low sick pay encourages the spread of communicable diseases. It discourages having higher sick pay. Better put it in the positive. Having higher sick pay would encourage employers to do more to look after the health of their employees. Before the pandemic, I'd been on an internal government campaign to significantly increase sick pay. I'd double it if I had a magic wand. So moving from 3 days to 1 day payment was a small step, which I obviously was necessary for the pandemic, but I enthusiastically embraced. But I would have gone far, far higher. We needed isolation payments from the start. We got them in the end by September, and I pay tribute to the Trade Union Congress for their campaigning on this issue, which helped me get it over the line.
And on that point, Mr Hancock, you may recall appearing on Question Time on the 19th of March 2020 and accepting in response to a question from Francis O'Grady, the then General Secretary of the TUC, that you couldn't survive on the £94 a week of statutory sick pay.
Yeah.
And
it should be higher. I think Francis O'Grady is wonderful and gave great service to the country in the role that she was in, and she made an argument that I very strongly believed in.
Sorry, Mr Hancock, I do have limited time. In fairness to you,
on one of my pets.
The TUC may not thank me for interrupting you in praising Francis O'Grady, but I better move on. In fairness to you, in response to questions from Mr Keith yesterday about Eat Out to Help Out, I think it was your evidence that at the time you were campaigning internally to get funding so that those who test positive would isolate, which you eventually got in place in September.
Yes, Dido Harding and I had a very strong campaign on that.
And who needed to be the target of that strong campaign, i.e. where was the resistance?
Well, we needed to get cross-government agreement, and that is the government's a large beast, so there were all sorts of people we needed to get on side for that.
Mr. Hancock, clearly you need cross-government agreement, but where was the resistance, straightforwardly?
Well, I can't remember. You'll have to look in the paperwork, but you need to have number 10 on side, Cabinet Office on side, and Treasury on side. For something like that, you'd also need to have the DWP on side, because although this was a pandemic and therefore I was driving it, it would typically be something close to their hearts as well.
Okay.
I can't remember precisely what the dynamics of that debate were.
The Test and Trace Support Payment Scheme came in on the 28th of September, Monday the 28th. I'm going to ask you about notes made by Sir Patrick Vallance of a meeting on the 25th of September, so the Friday before that came in. Okay, it's page 621 of the inquiry schedule of his notes, 273901. And we can see, Mr. Hancock, it says, cases, admissions and deaths all up. PM obsessed with testing again. Are people actually doing the self-isolation? So Sir Patrick argued that low levels of isolation is key. They, of course, go straight to enforcement. Hancock argues that it is all okay from Monday, and presumably that must be a reference to the Test and Trace Payment Support Scheme. PM says, we must have known this wasn't working. We have been pretending it has been, whereas secretly we know it hasn't been. Hancock lets out a big sigh.
Yeah, I feel like giving out a big sigh now.
Yeah, so firstly, but perhaps the question, the answer to this is obviously yes. Did you agree with that assessment of the PM? And is it...
No, I didn't. That wasn't how I felt about it.
Well, let me ask a different question. How did you feel about it?
Well, I don't think I hadn't been pretending to anybody, and I'd been making the argument as strongly as I could that we needed action, such as we were taking that following Monday.
Hence your big sigh. Do you think, though, that it's a pretty appalling state of affairs that 6 months after this measure of self-isolation becomes a key NPI, the PM's assessment is we have been pretending it has been working, whereas secretly we know it hasn't been?
I think that the lesson for the future is that self-isolation payments, rapidly delivered, are a necessity when self-isolation or indeed mandatory isolation is required. And my lesson, a further lesson I would take for the future from this whole debate in government is that we should have higher statutory sick pay, but I appreciate that's out with the terms of reference of the inquiry.
Mr. Hancock, the learning lessons point is clearly important. My question, straightforwardly, was do you agree with the characterisation that it's a pretty appalling state of affairs to be in at that stage in the pandemic?
I think that is unfair. There were enormous numbers of pressures, and these decisions and the positions people took were for good, rational reasons as far as I could see on this. I'm just very glad that we got over the line.
Next topic is movement of staff between care homes.
Yes.
Could we have on the screen your third statement, please, page 8, 273833, and in particular, paragraph 33. So you say, Mr. Hancock, in respect of staff movement between care homes, from the moment it became clear that staff movement was a vector of transmission, I pushed hard to limit and then ban staff movement. Various arguments against were presented, including that staff were essential for the sector, which of course they are, but I took the view that the need to stop infections getting into care homes was more important. Mr. Hancock, is that misleading in the sense that whilst it may have been true of your position later in the pandemic, in the first few months of the pandemic, it wasn't your view?
When I wrote this, I hadn't seen the paperwork from essentially February, March, which showed that some had been raising this issue, and at that time, the concern around, as it says here, staff being essential for the sector, was the primary concern because the vector of transmission point had not been had not been proven. And so my position on this is now more nuanced because I've seen further paperwork that on this matter.
Well, you say, Mr. Hancock, more nuanced. It's actually the reverse of the actual position in the early months of the pandemic, isn't it?
The critical point is this. From the moment it became clear that staff movement was a vector of transmission, early on we did not know that. It's all tied up with the asymptomatic transmission debate. And essentially when it became clear from early April that asymptomatic transmission was a serious problem, as opposed to being a suspected problem, which was the position earlier, then that has an obvious and immediate consequence in terms of staff movement being a vector of transmission. So it's all about the confidence with which you hold the different likelihoods. It comes back to the massive uncertainty early on.
Mr. Hancock, if it's known that a workforce is characterised by low-income, insecure work and that there's large movements between care homes, is it not a rather straightforward point that that's going to be a risk for transmission?
No, because if you think that transmission only comes from symptomatic people, which was the formal scientific advice to me up until the CDC evidence on the 3rd of April, as we discussed yesterday, then that does not hold so long as people who feel ill, symptomatic people, don't go to work. So that's the distinction. You see, if I may expand on that a little bit, the point is that limiting staff movement has a known direct negative impact, and as we'd seen, for instance, from Spain, could have very serious negative consequences. We didn't know with certainty I put it here, the vector of transmission. So you had a known negative and an unknown negative on the other side, and I was trying to balance these two things. But what I do accept is that my position on this is more nuanced than set out in paragraph 33, because since I wrote that, I've seen more documentation.
I'm sorry, Mr. Hancock. These are all matters you were aware of at the time. You were in the meeting rooms discussing these issues. These aren't matters that you have learnt about since this inquiry, are they?
I wrote this 3 years after all of that, and so actually looking at the paperwork has been a really important part of getting to the bottom of things.
Well,
yes.
Before I move on to my final issue, focusing on the action taken following April, when you say it became clear that it was a significant issue, could we have page 61 of the Valence schedule, 273901? So just to orientate ourselves, Mr. Hancock, it was on the 15th of May that your department issued discretionary guidance on limiting staff movement. And then 11 days later, on the 21st of May, care homes meeting, PM is now putting real pressure on them to sort things out, but still they won't stop people working across more than one home. This is a big issue everywhere, and we raised in Feb. So actually, Mr. Hancock is right, isn't it, that even after what you say you learnt in April, there were still others, it appears, including the PM, trying to push your department to go further, and you weren't doing so?
The situation was this. Until we had clear advice on asymptomatic transmission following the CDC publication on the 3rd of April, the advice was that, as I said, that if you were symptomatic and therefore didn't go to work if you were symptomatic, then that was essentially enough to address the problem given the known negatives of restricting the workforce. Once that advice changed, because the scientific advice was updated, and remember, I'd commissioned scientific advice on asymptomatic transmission on the 11th of March, and it had taken several weeks for that to finally come to fruition over in terms of asymptomatic testing in that case, the 14th of April. So there was, whilst that work was going on, the initial position was that stopping people with symptoms from going to work was enough. We then...
I'm sorry, Mr.
This is important. I'm answering your last question. We then put in place a strong guidance against working in more than one care home. That had the result of a 90% reduction in people working, the number of people working in more than one care home. I then wanted, to this point, to legally ban people from working in more than one care home. And the paperwork shows I pushed that all through the autumn. We got within days of announcing it a number of times. It was variously blocked, and eventually I dropped that proposal after it was finally blocked at the start of January 2021, and we brought in the third lockdown. So this was a point of great frustration to me. I hope that's a full explanation of the trajectory of this particular policy.
Just to remind you of the question, is it right factually that even after April, pressure was being put on you, including by the PM, to go further than the discretionary guidance? That never actually happened, did it?
I continued to push for full legal restrictions on working in one care home, and that I was not allowed to announce that. I couldn't get cross-government agreement.
I'm going to try and deal with the final topic in 1 minute, Mr. Hancock.
Okay.
Decision-making in education. 6th of August, you describe attending a meeting where plans for reopening schools in September are discussed, as are various contingency plans given the precarious R rate at that time. So, for example, the documents you exhibit talk about the possibilities of informing secondary schools that they may need to rotate and things of that nature. Sir Patrick, in his note of that meeting, describes the PM as saying, "Don't want to hear about plan B and C for failure. I just want pupils back at school. And we are no longer taking this COVID excuse stuff. Get back to school." 2 questions. Do you recall the PM responding to the scenarios and to contingencies in that way? And second, did that approach of having a plan A, not having a plan B or C, ultimately sow the seeds for the chaos that was to follow in respect of schools in subsequent months?
I don't recall the Prime Minister saying that, the then Prime Minister. And with respect to schools, we did end up putting in place other policies that you could describe as a plan B, including testing. But ultimately, as I said earlier, we had to pull all the levers and close schools in January.
That's factually what happened. But was there a problem of not having, in advance, careful contingency plans?
I'm not sure. I don't agree with the characterisation, and I think that taking one comment from a notebook doesn't necessarily capture what happened. Not least because we did have contingencies, for instance, to put testing into schools once we had an enormous testing capability by the autumn.
Thank you. I've probably pushed my time. Thank you.
Last questioner is Mr. Metzer. Mr. Hancock, who's down there.
Mr. Hancock, I asked you a small number of questions on 2 topics on behalf of the long COVID groups. You said that you agreed to put together a campaign on long COVID on the 31st of July 2020 at a round table which resulted in the public campaign launched in October 2020. This agreement came after Long COVID SOS wrote to you in July 2020 saying they were struggling to get help from the medical community for their disease and felt abandoned by the government. In the interim, Long COVID Support raised similar concerns with Jeremy Hunt, and you responded to a letter they wrote in September 2020. And in October 2020, Long COVID Kids also raised additional concerns in relation to long COVID in children in a public letter to the British Medical Journal. In January 2021, Long COVID Support wrote a letter to all members of Parliament still asking that long COVID be made of the narrative. We know, and you've said, that DHSC issued a press statement and just the one video on long COVID on the 21st of October 2020. One statement, no slogans were created, no public information campaigns were launched, and no further videos or press statements were released. You've said yourself that communication is an important NPI. Why wasn't more done to communicate the risk of long COVID to the public when you had long COVID groups repeatedly raising concern about the lack of communication?
Well, I'm very grateful to you for the work that you've done, the group's done on this. And writing to me in July was important because it made me realise that there was a problem that needed to be addressed, given that I knew about the impact of long COVID personally. And so hence I convened that roundtable and we took the action that we did. And we discussed earlier why it took 6 weeks from then to October, mid-October, to launch the plan. The only part of your question that I would disagree with is that there was only one comment put out. I repeatedly discussed long COVID on my own, both my own media appearances, my social media, and other areas. But it's absolutely true that it felt like it was an area that I felt I needed to push.
So do you agree and accept that insufficient was done to communicate the risk of long COVID to the public?
Well, I think that raising concerns about long COVID was an important part of explaining why it's important to tackle COVID. The large swathes of the public understood that and were on side for that. The campaign against it was ranged in a relatively small part of the political debate, if you like.
Well, you raised long COVID on your own, but why wasn't it raised across government?
I don't know. You'll have to ask people across government. I mean, I had my shoulders to the wheel on this one.
You said the only way to prevent long COVID is to prevent COVID. When decisions were taken to release restrictions in 2021,
yes,
wasn't it even more important to communicate the risk of long COVID to encourage people, including the young, to maintain protective behaviours to avoid long COVID?
Yes, I think that's reasonable. The pace at which the restrictions were lifted in 2021 was driven by the data with gaps wide enough to be able to see the impact of each restriction. I think this is important after the experience of lifting too much in 2020.
Well, do you accept, therefore, there was a failing to communicate sufficiently the risk of long COVID in 2021, particularly concerning young people?
I think that I haven't seen the amount of cross-government communication there was on it. All I can tell you is that this was something I was personally concerned about and used my own communications to reinforce the point.
All right. On the second topic, we know that the DHSC established external ministerial roundtables on the long-term effects of COVID-19, and these were chaired by Lord Bethell in October 2020.
Yeah.
You attended one of the roundtables on the 23rd of February 2021. Don't think we need to go to it.
Yeah.
INQ 0000600080.
Yeah.
Patient advocates also attended the roundtables and have said they couldn't see how the discussions translated into policy. The question is, how did insights from the roundtables inform the decisions that you and other decision makers made in response to the pandemic?
Well, what I'd say is that getting action on this subject was hard. And even as Secretary of State and with an excellent minister, Lord Bethell, who did a brilliant job during the pandemic, even with both of us pushing on it, it was difficult to get the movement that we needed within the NHS. You know, sometimes people describe working in government as wading through treacle, and long COVID was undoubtedly an area where I didn't get the responsiveness that I would have hoped for and did get in some other areas.
Can you explain why?
Can I explain why government works like that? I mean, crikey.
No, can you explain specifically why long COVID didn't get that attention that you personally felt it deserved?
I think it was because it was fundamentally difficult within the health system because of the very wide variety of ways it presents. In fact, I'm worried today that long COVID is not getting enough support, and I've heard rumours that there are some long COVID clinics that are under threat of closure, I think that would be a mistake. So sometimes in government you make a decision and things happen quickly, and sometimes you make a decision and nothing happens at all.
This will be.
It's not true to say nothing happened at all. We did open long COVID clinics. Many of them are still open today. As I said earlier, my mother is still a patient at one of them. So I still follow this issue closely. But I would just say that long COVID was one of those issues that is closer to the wading through treacle than the government machine responding as an orchestra does to their conductor.
Thank you, Mr. Metzer. No, sorry, Mr. Metzer.
Thank you, my lady.
I've been tough on everyone else.
Indeed.
Does that complete the questions for today? Mr. Hancock, that completes your evidence today. I'm terribly sorry, but I can't give you any guarantees. I won't be asking you to attend again in future modules. Thank you for your help over the last couple of days and for your patience.
Thank you.
Right. The next witness, so that people know if they wish to make any plans, will be Boris Johnson, the former Prime Minister. He will appear next Wednesday. We won't now be in a position to call Simon Case. That's due to medical reasons, and if people wish to see my ruling on that subject, they'll find it on the website. So it will be 10 o'clock next Wednesday, please. Thank you.